Hello everyone, my name is Felix Wiegandt and I'm a PhD student at Fraunhofer Institute for Toxicology and Experimental Medicine, Hanover, Germany. My presentation today focuses on a technology for breath-triggered aerosol release and real-time determination of the delivered aerosol for preterm neonates. When we treat someone by inhalation with an aerosolizer like the one on the right side, we obviously want to provide the patient effectively with as much aerosolized drug as possible. But, as you can imagine, the aerosolized drug can only reach your lungs during inhalation. When you use a conventional system without a breath trigger technology, you have a waste of drug during exhalation. This means that the efficiency of the delivered aerosol to the patient depends on the inhalation-exhalation ratio. Now imagine, we treat a preterm neonate who inhales for 0.3 seconds and exhales for 1.2 seconds. Now we fill our aerosolizer with 2 milliliter of liquid medication. Of these 2 milliliter, only 0.4 milliliter are available to the preterm neonate, which is 20% of the original amount, representing a loss of 80%. So we have an 80% loss of drug if we do not use breath trigger technology. However, if we use such technology, we can ideally reduce the loss to zero. Unfortunately, preterm neonates have challenging breathing patterns, such as a high breathing frequency of up to 60 breaths per minute, a low tidal volume of 4 to 6 milliliter per kilogram, and a short inspiration time of 0.2 to 0.4 seconds. Due to these challenges, there's no existing technology available, which releases the aerosolized drug into the patient interface in a breath-triggered manner. On top of that, if we had such a technology, there's no standard test procedure to determine the aerosol output accessible. What are we doing to address the problem? First, we are developing a novel modified nasal prong. This nasal prong has an integrated micronized valve. This valve allows direct and fast breath-triggered release of the aerosol as a targeted bolus, which increases the inhaled dose efficiency. Second, we are developing an appropriate test bench to measure aerosol output. The test bench is applicable for preterm neonate breathing patterns and also enables real-time measurement. Our first objective is the nasal prong. On this slide, you see a schematic structure. The aerosol and breathing gas enters the nasal prong on the right side. The aerosol release is triggered by an integrated micronized valve, which is controlled by adding or removing a defined volume of gas. The preterm neonate is inhaling the delivered aerosol over the two nasal tubes, which are placed in the nose. The non-inhaled aerosol leaves the nasal prong on the left side. Our second objective is the test bench. This picture shows the schematic structure of the test bench with the test lung, the aerosolizer system, the ventilation system, the nasal prong with its integrated aerosol valve, and the two measurement zones for the inhaled aerosol and non-inhaled aerosol. The test lung simulates the preterm neonate breathing pattern. During a simulated inhalation, particles are sucked through the nasal prong into measurement zone inhaled aerosol. Once there, these inhaled aerosol particles are first measured by the laser-based optical measurement unit, which uses light extinction, followed by sampling the particles on the filter. Particles not sucked in are guided towards the measurement zone non-inhaled aerosol during a simulated exhalation. These non-inhaled particles are then measured by the second laser-based optical measurement unit, again using light extinction, followed by sampling the particles on a second filter. To determine the aerosol release efficiency, a ratio of inhaled and non-inhaled aerosol is used. This ratio is defined as the collected inhaled aerosol mass divided by the total of the collected inhaled aerosol mass and non-inhaled aerosol mass. The used parameters are described on the right side. I will show you two videos to demonstrate the triggered aerosol release technology which we have developed. In the left video, you can see the integrated aerosol valve in action. The response time of the valve to fully close or open is less than 20 milliseconds. In the right video, you can see the triggered aerosol release. The release duration and the release timing can be variably controlled via the valve. This means that if the aerosol is released early during inhalation, we can treat the lower airways, and if aerosol is released later, we can treat the upper airways. This diagram shows the aerosol release efficiency for non-triggered aerosol release and triggered aerosol release. Here you can see that the triggered aerosol release at 83% is more efficient than the non-triggered aerosol release at only 26%. This is equal to an increase in efficiency by a factor of 3.2. Combining gravimetric and optical detection using the test bench, we were also able to perform real-time measurements. To summarize the aforementioned work, we have developed a modified nasal prong with an integrated micronized valve, which releases the aerosol as a targeted bolus, fast and directly into the patient interface. The breath-triggered release has increased inhaled dose efficiency. We have also developed a test bench to measure aerosol output suitable for the breathing pattern of preterm neonates in real time. Thus, our breath-triggered drug release system enables administration of high concentrations of aerosols, despite the very challenging breathing habits of preterm neonates. Our next step is to further develop the modified nasal prong and the test bench approach. That's it for my presentation on a novel technology addressing breath-triggered drug release for preterm neonates. I'd like to take this opportunity to thank you for your attention. Stay safe out there.